Hi everyone, this is Dr. Fawaz Siddiqui from Department of Pediatric Dentistry, and today we are going to learn about Pediatric Restorative Dentistry. We are going to learn about some of the restorative techniques and how do we restore a primary tooth. So this lecture on Pediatric Restorative Dentistry is part one of three-part lecture series, and subsequently next week you're going to look at part two and subsequently part three. So today I'm going to talk about the first part, and let's see what we have for our learning objectives. So by the end of this lecture you should be able to differentiate the morphological features in a primary tooth and in a permanent tooth, and try to differentiate between the two, because the anatomy is a little different and therefore our restorative techniques also differ. So we need to know about these differences, and once we have learned about the differences, we're going to look at the cavity preparation, and we are going to look at some principles of cavity preparation in general, and one that is pertinent to the pediatric dentistry, that is the primary molars and young permanent molars. So let's begin. So this is how my presentation would be spread out. So morphological differences, then we will be learning about classification of cavity preparations, and then finally concepts of cavity preparation in primary and young permanent teeth. So this diagram is quite famous, quite popular. You will find this diagram in quite a lot of books. This has been taken from Ingles Endodontics, and this diagram basically tells you the differences, that are 8 major differences between the primary molar and the permanent molar. The tooth that is on your left is the primary, and on your right is the permanent, and there are 8 differences. So let's look at one differences at a time and its clinical significance. So number one is the enamel cap of primary molars is thinner and has more consistent depth. So if you see, this is a bite-wing radiograph, and this one here is your permanent molars, and these are the primary second molar, primary first molar. So if you look at the enamel cap of the primary molar, you see that they are thinner as compared to the permanent. Look at the thickness here. So this thickness of permanent enamel is about 1.5 millimeters to 2 millimeters, while in primary it is only 1 millimeter. So you see the thickness is thinner, but this thickness is more or less consistent everywhere. So you'll find out, you will see that it's 1 mm all around, while here you will have more thickness near the cusp and less thickness on the sides. So this is more consistent depth. Then we have a comparatively large thickness of dentine over the pulpal walls at the occlusal fossa of primary molar. So because the enamel is thin, it is compensated by more thickness of the dentine. So if you see, the thickness of the dentine is much more because it is compensating for the enamel. So in the primary molar, the clinical significance is that the enamel is thin, so the caries spread is much faster, because as soon as the caries crosses the dento-enamel junction, in the dentine it spread much faster, and therefore involvement of the pulp is also much faster as compared to your permanent molar. Number one. Number two is that when you are doing a cavity prep, you will enter into the dentine very quickly, and the child may have sensitivity quite early, and you will be surprised that you haven't gone in deep enough and the child is already complaining of sensitivity. So you must keep in mind that the dentine thickness is compensating for the thin enamel. Number three is that it is very common for the pulp of the mesial pulp horn to get exposed very fast, because as soon as you enter into the carious lesion, you already crossed enamel and then you are into the dentine, and then the chances are higher of uh, exposure of the mesial pulp horn. So unlike here, if you see in the permanent, you have quite a thickness of the dentine, this is quite a thickness of the enamel, and you will not face the same problem as you will face while doing a cavity prep in a primary molar. Okay, so let's look at another one. Yeah, the pulp horns we talked about. Pulp horns are higher in primary molars, especially the mesial horns, and the pulp chambers are proportionately larger. So as you compare to the crown size and the root size, the pulp chamber is quite big, right? and therefore the pulpal exposure is quite common in primary molars, especially the mesial pulp horns in the molars. So same thing goes for the young permanent molar also. The mesial pulp horns are higher. As the molar ages, the secondary dentine deposition occurs, the tertiary dentine deposition occurs, the pulp horns slowly starts regressing until the pulp chamber itself becomes very small. And that is how, if you are trying to do a root canal in a geriatric patient, you will find the pulp chamber is very small and very difficult to access the root canals. So anyway, so remember, in primary molars we have high pulp horns, and especially the mesial one is quite high and the pulp chamber is proportionately large, and therefore when you're doing a cavity prep you have to be ultra conservative, ultra careful, otherwise you will expose the pulp immediately, and then we'll have to do some kind of pulp therapy, which means that your straightforward restoration gets converted into an endodontic treatment. The next point is the cervical ridges are more prominent, especially on the buccal side of the first primary molar. So if you see here, uh, the the cervical ridge here is on the buccal side. Okay, so it cannot be viewed in this bite wing, but if you see the cervical constriction here, yeah, it's quite abrupt. Okay, and you compare this cervical constriction, it's quite smooth. Okay, can you appreciate this part? So if you are putting a matrix band here, it's very difficult to get the adaptation of the matrix band in this particular area, and therefore you can have a lot of overhanging margins. So this cervical ridge being more pronounced, this part and this constriction, it makes it very difficult for the adaptation of the matrix band for uh, restoration of caries involving proximal surface. Unlike here in the permanent molar, it's quite smooth, so the adaptation is very good. So remember, cervical ridges are more pronounced in primary molars, and especially so on the buccal aspect. So this picture shows more clear-cut cross section of the primary molars. Here what I'm trying to show you is that the enamel rods, this part here, all enamel rods are sloped occlusally, so they are pointing occlusally, right? So this is one cross section and this is another cross section. So they're all the enamel rods in the gingival third are all inclined occlusally, unlike in the permanent, where in the cervical area in the gingival third the enamel rods are inclined gingivally, and therefore we need when we are doing amalgam restoration, we had to use gingival marginal trimmers to remove all the unsupported enamel, but it does not happen in primary molars because all the enamel rods in the gingival third are inclined occlusally. All right, then primary molars have marked constricted necks compared to the permanent. So this was what we talked about. This is what we saw in the bite wing earlier. So this marked constriction and with a cervical bulge, right, it gives us a very hard time when we are trying to adapt a matrix band for restoration of the proximal surface. So again, this is a clinical challenge in restoring a primary molar. Then we just come down to the roots just to complete the morphological differences. Of course, this is more to do with the endodontics, which we will also see later. But here, let us complete the discussion. The roots of the primary molars are longer and more cylindrical in comparison with the crown size than the permanent. So if you see, there is no root trunk here, but if you see in the permanent, there is a root trunk. Because this root trunk is there, the root are considered less cylinder. Cylinder is not cylindrical, pardon me on that, it's cylinder, right? So if you see these long thin roots, because there is no or very minimal root trunk, so this makes the fracture of these roots very common when you are extracting primary molar, because they're all thin and cylinder. Okay, cylinder, yeah, that's right. All right, so the roots of the primary molars flare out near the cervix, then do those of the permanent teeth. So if you see, to accommodate the developing permanent tooth bud here, the roots have to be flared out, otherwise the permanent tooth bud cannot develop here. So for the molars there is no tooth bud, so more or less these roots are within the confines of the crown. So if you see, if I draw a straight line here on the crown, the root will be within the confines, otherwise in this part the roots will come out of the confines of the crown. Okay, right. So here another bite wing. Can you see anything wrong with this bite-wing? Can you see these radiolucent areas? Yes, these are the proximal caries in the primary teeth. Okay, now primary teeth have contacts that are broad and flattened rather than being small distinct circular contact point as in the permanent. So just compare this on this side. Okay, see this broad contact area. So from here till here the contact is there. For here is of this one is the permanent molar, but this is a point contact here. See if my pointer, yeah, that is where it is. So because this is got a broad contact, any food that gets lodged or impacted under the contact point, it remains there for a long time because it cannot come out as it would come out in a point contact. So here the chances of proximal caries are very high in primary teeth. Then the shorter clinical crown lengths of primary teeth also affect the ability of these teeth to adequately support and retain intracoronal restorations. Okay, intracoronal restoration, that means restorations which are placed inside the crown. Now if you see the clinical height of this and you see the height of the permanent crown, because they're so small, it's very difficult, particularly when people were trying to do amalgam restorations, to get that resistance form, to get that depth into the dentine. It was very difficult because the tooth itself was so small, the enamel was so thin, the dentine was so thick, the pulp horns were high, the pulp chamber was bulbous, and therefore it was a difficult job to get an intracoronal restoration done, and that also of a long life. Then lastly, the young permanent teeth also exhibit the characteristic that need to be understood, especially when you're trying to do a restorative procedure such as large pulp chambers and broad contacts that are proximal to the primary. So here also, don't be surprised that you can get a food lodgement in this area because the contact point is dynamic, changing, and then you can also have proximal caries in the primary molar. So these are some of the differences between the anatomy of primary and permanent, which we should consider when we are doing a restorative treatment in the clinical scenario. The other classification that I want to share with you is the radiographic classification. You must have heard about incipient caries, moderate caries, advanced caries, and a severe caries. And this is what it is meant by that. So incipient caries is lesion that extends less than half through the enamel. Moderate is lesion that extends more than half through enamel but does not involve the dento-enamel junction. And advanced is lesion that extends to or through the DE junction but does not extend more than half the distance to the pulp. That means only the half of the thickness of the dentine is involved. And of course, severe is lesion that extends through enamel, through dentine, and more than half the distance to the pulp. So it's like very close to the pulp. So here it is very clearly seen. This is the incipient one. This is the moderate one, more than half of the enamel through the enamel and does not involve the D junction, and this involves the D junction but does not spread more than half the thickness of the pulp, and this is the lesion extends through enamel, dentine, and more than half the distance of the pulp. So when you say distance to the pulp, we are talking about distance, we are talking about the thickness of the dentine. All right, so now let's be clear on this one. Okay, so with these differences in mind and the clinical classification in mind, let me go through with you the treatment planning for restorative case. Okay, and the restorative treatment is based upon the results of the clinical examination and is ideally part of a comprehensive treatment plan. So clinical examination is very important, and for us we use IC-DAS system. So we drive the tooth and we examine it, and then we classify it as 01, 02, 03, 04, 05, and 06. And depending on that, we take some radiographs to see the depth of the carious lesion, and then it's whether it's incipient, moderate, advanced, or severe, and then we plan the treatment. But this restorative treatment plan is part of the comprehensive treatment plans. When say comprehensive treatment plan, means we are taking into consideration the preventive measures also and the recall plan also. Okay, so the treatment plan should take into consideration developmental status of the dentition, the caries risk assessment, patient's oral hygiene, anticipated parental compliance and likelihood of recall, and patient's ability to cooperate for the treatment. All right, so what basically it means that no point doing a complex restorative treatment for a tooth where the child is not going to maintain a good oral hygiene, okay, or the patient's compliance is very poor for the recall, and once the treatment is done, the parent disappears with the child, and then the parent brings the child back only when the child has got pain, and then you suddenly realize that there is secondary caries because there has been a food lodgement and the patient never came for a follow-up of your treatment. No preventive measures was put into the place. So when you're doing a restorative treatment planning, you must take into consideration all of this. So even the developmental status of the dentition, no point doing a complex restorative treatment or an expensive restorative treatment on a tooth which is going to exfoliate in the next 6 to 8 months, right? It does not matter. So maybe you can put a temporary restoration, we can last up to 6 to 8 months, and the tooth will exfoliate and the permanent will erupt in its place. Of course, it is very important to get the preventive plan going first and then starting your restorative treatment. Okay, we don't want our restorations to fail because the patient is not able to maintain good oral hygiene. So when to restore a particular tooth? Now, restorative treatment of dental caries alone does not stop the disease process, and the restorations have a finite lifespan. That means they have a limited lifespan. So if any patient is asking you, doctor, you've done a restoration, what is the guarantee the restoration will stay in place? Your answer should be there is no guarantee, because we have just stopped the disease process, but you have to take preventive measures to ensure the disease does not come back. All right, so remember, all the restorations have a finite lifespan. Some carious lesions may not progress and therefore may not need restoration. So you're also free not to restore carious lesions which have already become arrested and need not do a restorative treatment unless it is for aesthetic reason. All right, so the management of dental caries. Okay, let's summarize this. The management of dental caries includes identification of the individual's risk for caries progression. All right, that means if the risk is very high, that means first we need to control the caries progression, then we have to go and restore the tooth back to its normal function and form. Understanding of the disease process for that individual, that means the caries risk assessment. Unless we do something about the caries risk assessment, that means if the child is high caries risk, we have to do something to bring the child to moderate caries risk, and then we have to do something to bring the child to low caries risk. So we have to understand the disease process for that individual. Active surveillance to assess disease progression, right? So the recall is very, very important because we have to actively look for new carious lesions, new white spot lesions, new incipient caries, so that we can double up our preventive measures and try to avoid any cavitated lesions. Then manage with appropriate preventive services. So we have a lot of preventive tools at hand: topical fluorides, professionally applied topical fluorides, self-applied topical fluorides, and we have tooth mousse, and we have fissure sealants, and so many things we have at our disposal. So we have to use appropriate preventive services. Not to forget diet counseling, very important, and often we tend to neglect. Then supplemented by restorative therapy when indicated. So all this done, we have to supplement the preventive plan with a restorative therapy to maintain the good oral to maintain the patient's dentition in place, in service, till the primary tooth exfoliates and the permanent tooth erupts, and then again take care of the permanent, newly erupted permanent tooth. So there seems to be a lot of benefits of restorative therapy, especially when you do it for the primary teeth, because we are not only removing cavitations or defects, we are eliminating areas that are also susceptible to caries. We are stopping the progression of tooth demineralization, and we are restoring the tooth back to its normal function and form. We are preventing basically the spread of infection into the dental pulp, and we are also preventing the shift of teeth that due to loss of tooth structure. That means if you have a proximal caries, the tooth which is distal to that particular carious tooth will drift mesially into the carious lesion, and therefore we kind of save space. We try to preserve the arch length, right? So there's a lot of benefits of restoring a particular tooth. So our objective is basically to repair or limit damage from caries. So basically what we are doing is damage control. Then we are protecting and preserving the remaining tooth structure, and most importantly we are maintaining pulp vitality whenever possible, especially in immature permanent teeth for continued apexogenesis. So basically we when you do a restorative therapy, we are trying to protect the pulp, right, against the infection from the dental caries and keeping the pulp vital. So it is important in primary tooth because the pulp has to undergo changes which will cause root resorption in primary teeth, right? So we have to maintain the vitality of the pulp. And when we talk about immature young permanent teeth, that means the teeth which have newly erupted in the oral cavity, we have to protect the pulp because the pulp is taking part in the apexogenesis. So if anything happens to the pulp, the apexogenesis stops, and then the root development and maturation stops, and then we have a new problems. And this problem we will discuss when we will learn about pediatric endodontics. Okay, so for now let's remember the objective of restorative treatment are these three. But all this does not come, all of this comes with a risk, right? So what are the risks if you perform a restorative therapy? Number one, lessening the longevity of the teeth by making them more susceptible to fracture. Now, when you're doing restorations, you're cutting away tooth, you're cutting away the decayed part and also the some part of the natural tooth, and basically you are um, weakening the tooth structure, weakening the crown of the tooth, and this makes it more susceptible to fracture. Especially remember when we talked about the crown length of primary molars are less, where it is very difficult for an intracoronal restoration to do an intracoronal restoration. So basically, you can have crown fracture there. Then there are chances of recurrent lesions, recurrent caries, because of the pits and fissures in the occlusal surface. Then we can have a restoration failure. Your restoration may just fracture or may just pop out of the cavity that you had prepared. So you can have a restoration failure, or you can have pulp exposure during caries excavation. Like we discussed little earlier on the morphological differences, how the chances of pulp exposure is high in primary teeth. And then you can have future pulpal complications. Maybe when you are trying to remove the decayed area and trying to smoothen out the walls of the cavity preparations, the heat generated from your high-speed handpiece can damage the pulp. So you can have pulp complications. For example, you do a nice, beautiful restorations today, and the patient will come back after 3 weeks with irreversible pulpitis because the pulp has undergone irreversible damage because of the heat generated or because of maybe improper cavity preparation. A lot of things can happen. And then of course, iatrogenic damage to the adjacent teeth. So you're trying to prepare a proximal caries and then you slice off the proximal surface of the adjacent teeth because you're not careful. So again, the enamel is lost, which will not regrow, and therefore we will have another problem of food lodgement because the contour of the tooth has been lost. So these are all the risks of restorative therapy. So it's very important that before restoration of primary teeth, you must consider the benefits and the risk, and then only touch the tooth with your high speed handpiece or a slow speed handpiece for cavity preparation. Okay, bottom line to remember is you must also consider the length of the time remaining prior to tooth exfoliation. Like I said earlier, no point doing a complex restorative treatment on a tooth which is going to exfoliate in next 6 to 8 months or maybe maximum 1 year, and it is all waste of resources. All right, okay, let's see, go to the next. So how do you do a tooth preparation? All right, so a tooth preparation should include removal of caries. Okay, number one. Also removal of improperly developed tooth structure or unsound tooth structure. All right, so you have to remove all this. We cannot have a tooth structure which is weakened and which remains there, because it may fracture off later and become an area of plaque accumulation and food lodgement, and then we can have secondary caries. Then we have to establish appropriate outline form, resistance form, retention form, convenience form compatible with the restorative material to be utilized. So this having said, if you're doing an amalgam, you know what it all means, like outline form, resistance, retention, and convenience form. But if you're doing more, if you're using a restorative material which has got chemical bonding or micromechanical bonding, then at least you must remove all the caries properly, including unsound, unsupported enamel, so that you can have a good bonding. Okay, then lastly, cannot be overemphasized, rubber isolation should be utilized whenever possible, and this may not be possible in each and every patient. For example, a 3-year-old patient may not be comfortable with the rubber dam, and actually putting the rubber dam on a child may make the child uncooperative, and then we can have a lot of sort of problems. So try to understand this. The rubber dam isolation is necessary, especially when you are using restorative materials which require a very sound isolation. Okay, like composite resins, we must try to use rubber dam. Understand this part. So when you are trying to excavate the caries, the most important part is to get the dento-enamel junction free first, and the margins of your preparation caries free first. Okay, so you see here the margins in this particular is now caries free. All right, so once you get this margin caries free and you reach the dento-enamel junction, then you start excavating the caries in the dentine. All right, most of the time we tend to forget, we do incomplete caries preparation on the lateral walls and do a fantastic job at the bottom, and then we restore, and then we have marginal leakage because the caries has not been excavated properly from the lateral walls, and then the micro leakage begins. Okay, so step number 1 is to get the lateral walls caries free, number 1. Then try to remove things from the enamel junction, DE junction, and why and how we do, we will discuss when we actually discussing a few slides later. So let's go back from where we were. All right, so this was surprise, and then the caries removal techniques. Now there are different techniques of caries removal, and researchers have gone and done a lot of caries excavation to come to these conclusions. So basically there are 3 methods of caries removal. Number 1 is complete excavation, which means that all caries dentine is removed, everything is out, everything is white and shiny. Okay, another one is stepwise excavation, and this is a 2-step caries removal process in which the caries dentine is partially removed at the first appointment, leaving caries over the pulp with the placement of a temporary restoration. At the second appointment, all the remaining caries dentine is then removed and a final restoration is placed. So basically it means that you are doing an indirect pulp capping. All right, but here you must remember that the lateral walls are caries free. It's only the caries on the over the pulp that we are leaving behind. Okay, so in stepwise excavation, you do partial caries excavation, and then you put a temporary filling, maybe a calcium hydroxide dressing with a GIC, then wait for the pulp to form tertiary dentine and reparative dentine, and when the patient comes back after 3 to 6 weeks later, the thickness of the dentine has improved on that area, the dentine has remineralized, and then you have to remove whatever caries dentine is left behind without fear of exposing the pulp, and then you place your final restoration, which could be a posterior composite or a dental amalgam if you're still using dental amalgam. All right, then the last technique is partial or 1-step excavation, and here you remove the part of the caries dentine but leave some caries over the pulp and do the final restoration along with the base in that same visit. So you basically don't call the patient back again to remove the remaining caries dentine. So it is only 1 step done. That means you are doing an indirect pulp capping with a definitive or final restoration in the same appointment. So even if there's some caries dentine left behind, you put a layer of calcium hydroxide over it, hard setting calcium hydroxide, put a base of GIC, and directly go ahead and do a posterior composite restoration, and you are done. You don't need to look back again at the caries removal. Now this is because once the caries has been removed, then there's no food lodgement. Basically the bacteria cannot survive, and especially with calcium hydroxide in place, the bacteria slowly dies off, and the pulp has an opportunity to deposit the tertiary dentine, the reparative dentine, and the pulp is protected, and the infection subsides and the caries progress stops. So this is the idea behind partial or 1-step caries excavation. So in this diagram, I want you to appreciate that when you're talking about caries dentine, there is an affected dentine and there is an infected dentine. So the infected dentine is the outer dentine. So if this is a caries lesion, these all leathery dentine, soft is the infected dentine, and it has bacteria, it has dead uh, tooth structure, and does not have any sensation because it's already dead, and it's not very useful for us. But the inner affected dentine, that means if you see the borders here, now this dentine only has a color change because of the toxins and produced by the bacteria, but this dentine, the affected dentine, can remineralize, and it is sensitive and it is vital and it is important for us to preserve this affected dentine. So if you remember that the complete caries excavation, in that you have to remove all the infected and affected dentine all together. All right, and when we were doing this, most of the time the tooth the pulp was getting exposed, and our simple restorative treatment was converted into pulpotomy. Okay, and that was a longer procedure with a poorer prognosis as compared to a simple restoration. So over a period of time, researchers found out that if you only remove the infected dentine and let the affected dentine remain, and you cover it up with a liner and a base and a restoration, the affected dentine will remineralize and there will be no pulpal exposure. The pulp will get protected. Okay, the vitality of the pulp will be maintained. So when you're doing caries excavation, you must understand the differences between infected dentine and affected dentine. Okay, in this particular slide, again, it's a very good slide taken from literature. It shows us the enamel cavitation, the destruction of the DE junction, the bacterial invasion, the area or zone of demineralization, followed by the sclerotic dentine, followed by the tertiary dentine. Okay, so this is the tertiary dentine we're talking about, giving an opportunity for the pulp to uh, form tertiary dentine and protect itself from the invading bacteria. So this is a very good slide for you to understand the different zones or the layers when we talk about cavitation. This diagram again shows us that the caries excavation. So here the blue line is your prepared cavity, all right, and the yellow line here is your initial caries affected dentine, okay, and the red line is your initial infected dentine. So red line is infected, yellow line is the affected. Okay, so now if you see the overlap, you will find that once you finish your caries excavation, all right, to the naked eye you will have some affected dentine remaining, all right, and there will be some residual infected dentine also after you finish your caries excavation. All right, so the blue line is here. So once you finish caries preparation, this is your cavity preparation here. Okay, but at the corners you will find that there is some infected residual dentine and there is some affected dentine also. So this slide basically tells you that how careful you have to be when you're doing caries excavation, that you have to get rid of the infected dentine, especially at the corners of your preparation. That means your cavo surface areas, you have to get rid of them. There should not be any overhanging enamel margins in this area because they will be protecting this part of infected dentine. Okay, so if you see this area here is what is shown here. Okay, so once you're doing caries excavation, ensure that cavo surface is nice and clean. All right, because if this infected dentine, if you're not removing, all right, over a period of time this will disintegrate and the food lodgement will start, and then the plaque accumulation, food lodgement, and new secondary caries or recurrent caries will start, and it will reach to the pulp very fast, and from the top it will look like as if nothing is wrong. So this slide basically tells you how careful you have to be when you're doing caries excavation and cavity preparation. So what are the different restorative materials that we can use at hand? I have listed out some common ones for you. Glass ionomers, right? They bond chemically to the enamel and dentine. Fantastic. Thermal expansion is very as is close to the dentine. That means when the dentine expands because of extreme temperatures, the glass ionomer expands at the same coefficient, and therefore there is no micro leakage. So it's biocompatible, and most importantly, it releases fluoride and we have resin modified GIC, which have got a superior strength as compared to your conventional GIC. And then we have high viscosity GIC, type 9 GIC. So a lot of things have happened with glass ionomers in conventionally used, and you need to be updated on the different types of GICs that are available. For us in the clinic, we have type 7, type 9, and resin modified and light cured GIC. And then we also have Acmina food, right? So we have a lot of options when we come to glass ionomer cement, and we must be sure on why are we using that particular glass ionomer cement. Okay, for example, if you're doing two-step caries excavation, then I expect you to use type 7 GIC, which is a high fluoride release GIC, as your restorative material of choice in the appointment 1, and your posterior composite in your appointment 2. Okay, and then you must tell me, sir, I'm using high fluoride release GIC, that is type 7, because I'm doing a two-step caries excavation. Okay, I will agree with you, there will be no debate on that, and then you can proceed. So you always have to have this clinical judgment, and we have to take a clinical decision on why you're using the particular restorative material. So this is GIC. Then we have resin based composite, right? So in the market currently, posterior composite or high strength hybrid composites are having a strength to withstand masticatory forces. All right, so even the GIC does not have, in the resin modified GIC does not have that strength. So this is indicated in class 1 cavities, class 2 restorations, and also in class 3, class 4, class 5, because all of this requires aesthetic restorative material. And then we also use it for strip crowns that we will discuss in the next lecture or so in primary teeth. So composite is very dynamic. All right, it's got a lot of varieties in the market. You have hybrid, you have highly polishable composite, you have bulk fill composite. So a lot of things are there in the market. What we use in the clinic is um, which one is that? ZX350, right? That is high strength. ZT350, and then we also have 250. And then, like I told you, we have to decide on which one we are using for a particular case, and then give a justification for that. So it's a very robust restorative material, can be used anywhere. But when we talk about pediatric dentistry, there are certain contraindications to using a composite, and here in these cases you have to rely on your GIC for restorative purposes. So what are those contraindications? You have a tooth that cannot be isolated properly. Maybe it's a newly erupted tooth or half erupted tooth, tooth with regressing operculum. All right, there you have to go for an interim restoration with GIC, and then change that interim restoration to composite when the tooth completely erupts or when the moisture control is much better. Then in individuals needing large multiple surface restorations in the posterior primary dentition. All right, so in primary dentition the tooth is so small, and if it is a multi-surface caries, then you need to go and do a stainless steel crown, and don't go and do composite, even GIC. Right, so remember this part. Then in high risk patients who have multiple caries tooth, and or tooth with demineralization, or children who exhibit poor oral hygiene, and the compliance with daily oral hygiene is a problem, and the maintenance is considered unlikely. So better do a glass ionomer restoration, so that we can have some fluoride reservoir going on into the mouth, and it can help us to overcome these problems of poor oral hygiene, and the patients not reporting back for maintenance phase of your treatment, is not maintaining good oral hygiene. So you don't use composite resins there. Rely on stainless steel crowns, or go ahead and do a type GIC restoration, type 7, type 9, whichever. Okay, so in these particular cases, don't use composite because they will fail miserably, and composite is more expensive than GIC, and the patient will ask you to redo because your treatment has failed. So they will always come back for a free treatment or a free restoration, wasting your resources, your chair's time, and of course your efforts. So don't do composite restoration in these cases. Then we have compomers. These are basically a combination of composites and glass ionomers, and these are flowable material, so that means they can flow, and because they are combination of composite and glass ionomer, they have an ability to release fluoride, and they have an aesthetic value also. All right, so in cases where you need fluoride release and aesthetics, but strength is not a problem, all right, then you go ahead and can use compomers. So compomers can be used in your CAR type 2. You can use CAR, you can use compomers as uh, in class 3 cavities, class 5 cavities, in primary teeth. So it's that way. It is a very versatile restorative material. All right, so with this we come to the end of the session. Remember, there are many restorative materials available in the market, and any restorative material that you pick up or choose for use, you must have sufficient justification for that restorative material. So you need to understand what does the restorative material do, what are the physical properties, how it is manipulated, and how it can fit into your practice. All right, so with these thoughts, I end my sessions, and in this session we'll quickly summarize what we have learned. We have learned the morphological differences between primary and permanent and their clinical significance. We have also learned on the caries excavation. All right, we have also learned on the treatment planning, and we have also learned lastly is your restorative material. Okay, so I hope this session was useful for you, and in the next session we will look at some of restorative techniques in particular, and stainless steel crown and strip crowns and aesthetic restorative procedures later on. All right, so that is it from me, and I wish you a good day. Bye bye.